So when a blood clot breaks off from another part of the body and enters into the pulmonary circulation, it is called pulmonary embolism. These are usually, they can be small blood clots, they can be large blood clots. Usually the main origin of blood clots that go into pulmonary circulation is the lower limb, called deep venous thrombosis. And sometimes the upper limbs also can be a source of the embolas. So look at this diagram. This is the heart and this is the pulmonary artery. The pulmonary artery, the main pulmonary artery, divides into two. There's the left pulmonary artery that supplies the left lung and the right pulmonary artery that supplies the right lung. The work of the lung is to do gaseous exchange, to remove carbon dioxide and to bring in oxygen. And so there's a very close relationship between these arteries originating from the pulmonary artery. These ones end up being called lobar arteries. So a blood clot can come from the lower limbs into the right ventricle and into any part of this circulation. So if it is in the main pulmonary artery, it's called a saddle embolus. If it's on the left pulmonary artery, it's called left pulmonary artery. But sometimes the blood clots are so extensive, they can just be everywhere on the left pulmonary artery, the right pulmonary artery. They can even go into the lobar arteries in what is called extensive pulmonary embolism. The nearer the blood clot, those embolas, are to the heart, the more severe the shortness of breath. And the more distal it is, the nearer it is to the lung, the symptoms can be irritative. So your patient can just be coughing nonstop and the cough can be blood-stained. So it depends on where the blood clot is around here. So if it's near the main pulmonary artery, near the heart, it can actually be fatal because it means that blood flow here cannot enter the pulmonary circulation. There is some obstruction that is happening there, and then there is usually increased pressure around here because the heart is trying to overcome this blockage, and then usually it leads to dilation of the right ventricle because the heart is really struggling to push blood. And when the heart struggles so much without being helped, if the blood clots are so many, then that's how patients usually collapse and they just die. So what are the symptoms for pulmonary embolism? It's quite common, but the symptoms can be very non-specific, and actually a lot of pulmonary embolism has been missed because the symptoms are really neither here nor there. So one of the commonest symptoms is acute shortness of breath. That should be a red flag for pulmonary embolism. Some patients will tell you they're having chest pain. All right. Some people can just feel lightheadedness and then they faint. Syncope, dizziness, or lightheaded. As I said, cough that can be blood-stained. And these symptoms can be confused for a myocardial infarction. And sometimes even among experienced people like myself, it can be a bit difficult to tease it out. Yeah. So a high index of suspicion is required to make a proper diagnosis of pulmonary embolism, but it's very common and it can be life-threatening. All right. So how do you diagnose? So pulmonary embolism is divided into depending on how the patient is presenting and how the vital signs are. So whenever patients come in, we do blood pressure, we check the heart rate and the oxygen saturation. So then you can classify your patient into hemodynamically stable pulmonary embolism. So if it's hemodynamically stable, in the past it was called submassive pulmonary embolism. It means that the clots aren't really overwhelming the system. And in this case, the patient's blood pressure, oxygen, and the heart rate will be normal, despite them having the symptoms of shortness of breath and chest pain, but the vitals are normal. So that's hemodynamically stable PE. On the other hand, the most severe one is hemodynamically unstable pulmonary embolism. So this is a patient who's coming in with symptoms and then their blood pressure is so low, the systolic is less than 90, and then they could be having tachycardia, increased heart rate, and the oxygen saturation can even go as low as 80% in hemodynamically unstable pulmonary embolism. Yeah. So there's what is called, there are two scores. There's Wells score and then there's Geneva score. So the higher the Wells score, the higher the probability of having a pulmonary embolism. And the patients who have a high Wells score, meaning a high probability, those patients will just go in to do CT pulmonary angiogram. CT pulmonary angiogram is like the gold standard. It's easily available. It's done in many hospitals. So you inject a dye and then you scan just to see if there are any filling defects on the pulmonary artery. For patients who are pregnant and you're suspecting pulmonary embolism, or if they have kidney failure and the GFR is less than 30, or if someone has got allergy to contrast and there's no time to organize for anything, then you can do VQ scan, which is perfusion scan. It will show you if there's any perfusion defect, and it's done in Aga Khan actually. And then there are other ways, other diagnostic methods. So chest X-ray is usually normal. So if you do a chest X-ray and it's normal, but your patient is having shortness of breath, that should be a red flag for pulmonary embolism, and you should organize for a CT pulmonary angiogram. Sometimes is what is called Hampton's Hum, something you can see on chest X-ray to show you that it could be pulmonary embolism. You can also do an echocardiogram for your patient in the emergency room. You can do an echo. The echo, usually red flags for a pulmonary embolism is RV, the right ventricular free wall is not contracting, so hypocontractile RV free wall, while the apex of the right ventricle is contracting well. There's a sign for that. And then the right side of the heart will be dilated. The right ventricle will be big and the right atrium will be big, and then the pulmonary pressure, the right ventricular systolic pressure on the right side will be higher than 40, which is abnormal. All right, but the echo is not really confirmatory. You can't do so much unless if your patient is so unstable and the symptoms are acute. Maybe this is a patient and you know that the echo on the system, if you check the echo, it was normal like a month ago, and then when you repeat an echo and you're just seeing all these changes on the right side, RV dilatation with elevated pressures on the right side, then you can use that if your patient is so unstable for CT, or if the kidney function is so poor, or if a patient is pregnant. For pregnant women, we don't subject them to radiation because of the baby. That's the only time you can use echo to start your patient on treatment. So actually the teaching is, if the Wells score, the probabilitic score, if the Wells score is so high, you need to give the patient heparin first before taking them for CT pulmonary angiogram. So you give them a low molecular weight heparin injection, and then you take them for imaging. So how do you treat? So for patients who are hemodynamically unstable, you need to give thrombolytics, which are clot busters, and we've done it, and we have those thrombolytics. And this is because if you don't thrombolize and the patient is hemodynamically unstable, the chances of dying are very high, and you do not want that. So mortality rate is high in untreated PE. The other thing, if your patient is hemodynamically stable, the blood pressure is normal, you can start low molecular weight heparin, admit them. If you can, it depends on how the patient is, flow or HDU or ICU. And then once your patient is stable acutely, then you can discharge them on warfarin or on the new anticoagulation like a Pixaban, Rivaroxaban, dabigatran, those ones you can, and then you follow your patient up. A few patients will get complications called chronic thromboembolic pulmonary hypertension, meaning the pressures on the right side become elevated, and now your patient can go into right ventricular failure, or they can just have pulmonary hypertension. So patients need to be followed up into the future. The duration for anticoagulation is 3 months. A few patients will get 6 months, others will get a year, and others will get lifelong anticoagulation depending on the risk factors that you've identified. So that's how you go about pulmonary embolism, because it's very common and it can lead to increased mortality if you don't do that timely diagnosis and timely treatment for your patients.